What did you call me and what good news are you talking about?
I am an accountable care organization administrator. That is ACO for sure. We are a hospital and doctor group. You have been selected to participate as an attributed member. Congratulations, because my organization is going.
So I think, so the way we have tried to approach this is through really taking a really deep dive, and the first thing which we are trying to do is to really design a care model, a 2020 care model, which is these are the workflows which helps us to. This is our roadmap. So on your extreme extreme left-hand side, you can see the clinical redesign. These are all our care management programs, and I'll touch base quickly on that later on. And then in the middle is our communication. How do we really, as a physician or a clinician, communicate with our patients? How do we have on-stage leadership? Improving access to care, which is really the biggest thing for us. Means in San Diego, the weather is hardly changes any time. The only thing we talk about around water coolers is, what's the access today. So I think peer-to-peer review, how does the quality goes around, what's internal quality check for us. And on the right-hand side is all the things which we are trying to have the presence in the community. The health coaching, the healthcare education classes, having patients representative on our committee. So when I think about your left-hand side is all the things which we do for population management. But when we start adding what's happening on the right-hand side with our community, then that's what truly is population health. And I think sometimes we tend to confuse one from the other part. So, for any kind of care roadmap, the first thing we have to do is measurement. And I'll let you read this code. So, like Deming said or Harrington said, you can't improve what you cannot measure. So the first task for us is that how can we get really clean data? So having everyone, all of our treating people, participating clinicians on a common electronic health record platform helps. Also, when we have a flag there, you cannot click on that flag and see which member of your continuum of care, which of the diabetes nurses, which of our CHF nurses is following the patient, their phone number so that they can, anytime the back office, front office, a physician needs to contact someone, they can do so. So having everyone on the EHR, having a structured data and analytics helps us to really risk stratify the patients. Today we have risk stratified the patients into 4 tiers. The tier 4 is our complex patient. These are the 5%. These are the 5% of patients costing us 55% of the money. These are the most difficult patients we have. 15% are people who have more than 2 hospitalizations. 20% are people who have chronic illness. They have 1 or more illness, and we're trying to really make sure that having evidence-based guidelines like hypertension, for example. And 60% are people who are walking well people. These are people like you and me who just need periodic reminders to come, make sure that they are healthy. As much as possible, we want to get the 60% to be 65% and higher. And so, and the end goal is to keep people healthy, happy, and at home. So, the other component, which the data, the analytics, and we have a pretty good team, and they really build nice disease registries. And here you can see that it has all the necessary clinical components. Here the diabetes registry shows all the necessary labs. They are color coded for being out of range. What's the current medication? What was the last appointment? When is the next appointment? So this is really helpful for as a point of care tool for the physicians and clinicians. They can look at one place and try to close the gap in care as quickly as possible. Also, the data helps us to really hotspot our population. Here you can see that we have used our internal data to track where our hypertension population is, and we can see that in East County of San Diego we have a higher number of people with uncontrolled hypertension, and that's the place where we are going to target, where we're going to have more staff and more resources in that area. Also further, we are trying to further risk stratify the patients by using things like the Framingham score or the new atherosclerotic cardiovascular disease risk score, the ASCVD risk score. So that's really helping us to really bring up the people who really need our help or who have a low bundle diabetes score. So now we have all this process, now we can now start, have some automation around workflows. So here, for example, is a chart of all the patients for that one side who have an A1C from 5% to 9% range, people, 5% to 9% of prevalence of the population. And this list now on a monthly basis goes directly to our diabetes disease manager. So they know which cases they have to target, on a monthly basis. And once they have this, then we have we have the standard workflow using again the electronic health record. We have structured data feed, and everyone is trying to assess the patient in a very standard way. So they are identifying the barriers, they are identifying the medication, but also having a structured data field allows us to really extract the data and look at what are the gaps in care which we need to address. It helps our directors, it helps our managers to make sure when they're auditing the chart that every case manager is really doing the same thing, means everyone is following the similar protocols. Unlike that lady on the video clip, we can hopefully address those issues earlier than later.
Before you leave that slide, would you mind reading some of those questions, because those might be useful to others.
Right. So I think, for example, this is just a one. There's a lot of things, but I just took a small screenshot. But like, how do you feel that you're currently able to manage your diabetes? What's your biggest concern right now about diabetes? And does your current cultural heritage or spiritual personal beliefs conflict with your doctor's recommendation? I can prevent complications, and what is your feeling about health, diabetes? So in general, these are some of the social, cultural questions, really trying to address the barriers in healthcare. So now we have, created all these workflows, all the things automated. The great part for me is everything is automated. By now, everyone is getting their list. They know what the standard assessment is. So everything has been automated to this stage, and now things are going to your team. So the question is, who is on your team? So the way I think we are trying to do is, we're trying to make sure everyone is working at the top of their license. So using the same risk stratification, on your right hand side, on the top, there is a person there's a team now called as triage nurse. They like to be called as nurse navigators, so that's what we call them now. But the nurse navigators, make sure that they do initial assessment, and based on the needs of the patient, they assign the patient to the proper tier. For example, a complex patient might be seen by a nurse practitioner, social worker, case manager, while on the bottom, a person who needs just periodic reminders may be done by care coordinators, diabetes educator, or health coaches, or pharmacy tech. And I'll go over some of the roles of each of this, but the purpose of this whole intake process or nurse navigator is so that the people are working at their highest scope of license. That's what the goal is. And people do move from one tier to another tier, and that's a key point. I think we have to always remember anytime we are designing population health programs. And this is an important slide for me. I think all of us know, clinicians in this room know that people just don't have diabetes, right? They have diabetes, obesity, sleep apnea, arrhythmia, family issues, all these things are happening. And they're seeking healthcare not only at their clinic, but they're also seeking healthcare at the SNF, home, retail clinic, or hospital. So we have to make sure that the standardization of care happens at all places of service. For example, if today we have new hypertension guidelines in place at group level. It's not only important that the clinic physicians know, but tomorrow I have to go and talk to the hospitalist. I have to make sure that the home team also is assessing the blood pressures properly and the medication regimen is being followed. So all these places, we have to make sure they're flowing seamlessly, and everything is working well here. So my role here is in the center, that's the medical director of continuum of care. So it takes me 10 minutes to describe my role sometimes. I wish I had an easier title than what that is. But that's, I think, we think of this as really making sure the transitions of care happen smoothly across all places of service. So I think when we look at all the members, and some of the members listed here, on the top are people who have our hospital and safe case management. They truly help with discharge planning. We have the complex case management. They're helping with catastrophic cases, dialysis patients, DME, supplies, and all those things. Chronic care nurses are our case managers who are embedded in the clinic. They really are co-located with primary care physicians offering shared visits for high-risk patients. We have disease managers who are like diabetes disease managers who are in the clinic, or sometimes people are working remotely and helping care for congestive heart failure, COPD, or asthma. And then pharmacy programs, I think you have heard very good about pharmacy programs, but they are an integral part of our continuum care teams. They help with medication therapy management. We have stopped calling them refill clinic. I think I think they do so much more than just refilling medication. And then healthy living is our community presence, which is group classes and peer support. We have I think a very good obesity program. It was ranked number 2 in the US News. But I think looking at all this chronic disease program and presence in the community. We're also looking now into a pilot with mental health integration, where we have psychotherapists in the clinics for the common illnesses which really can be a barrier to healthcare, and they're trying to really help out. It's a pilot, we'll see how that mental health thing goes. So all these people are part of the continuum of care team model. And then we are trying to optimize, operationally. When you see, I'll just walk you through some of these data points here. But I think we're trying to optimize care team roles. Each team has a caseload of what's the caseload, how many people they refer, how many people they engage, what's their clinical outcome, and every time this report we track it very closely to make sure that people are again, making sure that they're seeing the right people, they're getting the referrals. But as a clinician, sometimes we have this tendency to hold on to patients, right? But when you're working in a team, the most important thing is to really pass the baton to the next person. And I think we have to delegate, we have to pass on. Otherwise, we'll just be stagnant with the number of patients we can take. So we have to constantly move, and I think we work with our case manager team to make sure that they are turning over cases, because the end goal is self-management of their own chronic illness. So now I think we have looked at who are the people on the team, all these people, and you could have your own spectrum of the type of personnel you have in your teams. But then how do we know how effective are they? So here's a question for the group. One effective way to engage patients in self-management of their chronic illness is no one for option B? I like dictatorship is easy. But I think, I think when we look at, yes, being part of the care team, I think we saw from the clip, patients tend to connect with us more when they see that a primary care physician walks you and says, here is Mr. Smith, he's going to take care of you as for your diabetes. I think patients tend to relate to, they have a higher tendency of engaging once if they are identified as part of the care team. So that's the correct answer. So I think when we look at, this is a huge, this is itself is a big topic, but I think what we are trying to tell our team is, look, patients have chronic illness for a long time. They have had obesity, diabetes, hypertension for a long time. In today's day and age, people know about their problem. They know that this is not the right thing to do, right? But still, we have to engage them in a one step at a time. Just saying hello and calling you back or coming back to the clinic itself is a big step. So that's how we measure engagement also. So forming that, having that personal connection, there have been very good studies showing that when you have a personal connection, patients tend to adhere more. And then, having a shared care plan, and all these things really help to partner the patient or engage the patient in their ongoing care. So here's another question for the group. For more efficient management of patient population, go ahead, you can. What do you think is A, B, C, D? Well, the correct answer here is C, correct, that's good, because there was a paper, a very good paper by Dr. Hibbert, I think most of you know, she has done phenomenal work on patient activation measures, the PAM tool. And it's, we risk stratify the patients, right? We say this is your high risk, your low risk, medium risk, but having an engagement score or an activation score beyond that, helps us to really look at really meeting the outcomes. So just risk stratifying does not work itself. We have to look at engagement score. So when we look at our population, this is a screenshot of an old report, but you can see for each of these diseases, we are now starting to measure what their patient activation score is. And if it's good, high, great, let's continue doing the good work, but if it's not, why is it not working? What's going on? This is the thing which we constantly discuss to say, how can we improve our motivation in during service? How can we, are we reaching the right patients? What are the things we can do differently to really engage patients? We also see that when the team members are co-located at the practice sites along with their primary care or longitudinal specialist, or they have a common electronic platform, the engagement rate jumps up significantly. And I think that's why when people say that I'm going to fax you papers or something, it does not work, right? Most of the time as a clinician, you know where the fax goes when you get it. It goes into the blue recycling file bin. So I think in a way, the more people co-located, working as a team, the engagement rate is higher. And then these are the tools which we are trying to use to really drive, how patients can have their own shared action plan. Here's a simple tool about blood pressure. What's my blood pressure check? What's one thing I'm going to do before I go home, when I'm at home, before I see you the next time? Is that, am I going to cut down on smoking or take my medications? And medication is become a big issue for us. Medication adherence is, for Sharp-Stili, is number one challenge we have. I don't know what's going on in San Diego, but either our patients, either our data is wrong, that people are getting their medications from Navy, or I think they're also going to Mexico, TJ, and getting their medications from there or something. But we have a huge challenge, and that's why we continue to promote the role of pharmacists in the care team. And I know that Hattie, you have one of those triangles, and that's an important thing. But they as a part of this is just, and I think you already had a very good, I heard that you had a good presentation last time on this topic, right?
Yes.
So, but I won't go into details, but here you can see that before they fill any medication, the pharmacists are helping to make sure that their patients are having the protocol, and all these things are done. The clinicians have been so happy now with this whole service for years now that they have said that, look, to really have excellent care and safe practice, we should have a pharmacy team start refilling our medication and following this protocol. So I think 99.9% of PCPs have given up, besides narcotics, have delegated this to the pharmacy team, and they're doing great work. And we continue to expand the role of pharmacists in our programs. But the end goal for us is how can we really get people to really self-manage. We'll never have enough resources, we'll never have enough people to really take care of all this thing. So here is a healthier living class. Healthier living class is a model based on Stanford, and I learned about it a few years back at Hattie's conference at Berkeley when the Stanford people came and presented on this. So yes, I did learn something from you, Hattie. But I think we did, we have at one site, for example, 15 workshops, almost 118 participants took part in this, 63% completion rate. I think the rate would have been higher had it been for San Diego traffic. But I think we will continue to see how we can use different ways to have people participate in this workshop. Because that's the end goal. This is all peer-to-peer. There is no physician, no one. People have to drive their own choices on how they're going to manage their chronic illness. So when you look at overall for population health program right now, we see almost a high engagement rate of around 62% in our group, which is very good. I think, and we continue to see how we can tweak so that we can get a little bit higher numbers. But also we are starting to see new disciplines coming into this whole thing. There is a whole new thing about health coaching. As part of CMMI grant in San Diego, one of the interventions we are doing is on health coaches. And you can now see, so what are your thoughts? What do you think the people who are entering the field of health coaching include? Right, all of the above. It's so interesting. I think when you look at the 8 healthcare systems, and each healthcare system is now hiring health coaches, they have varied backgrounds. Respiratory therapists and pharmacy tech, and MAs who are super MAs who are now health coaches. So I think it's a good thing. But the thing which we have is, the challenge which we have now is, what should be the standards be for health coach? Because this is a non-licensed clinical person, right? What should be the standards be? And how does one measure engagement? Because they can reach people in a very different way than a traditional RN case manager does. So we have to, this is something I don't have an answer right now, and I hope the next time I'm here in 2018, I think I could come and tell you some of the answers on this, what the health coach role is and how we identify them. So, but whatever we do, I think the point here is that we have to speak the language of the patient. We have to be simple. We have to, patients have to understand us. The conversation is when there is a dialogue. When two people are talking, understanding each other, and we can then try to problem solve what their issue is. And just to drive home this point one more time, so that when you go back to work on Monday, work back on Tuesday, I think you can see. You can remember this point. So here's a clip I want to share with you.
Das hier ist ein Mindsektor.
This is a German Coast Guard new recruit,
Das ist das wichtigste Gerät des Küstenwächters. Das Gerät, das Überlebensradar.
Hello? This is the German Coast Guard. What are you thinking about?
So, we have to speak. I hope you remember this. So let's move gears, and talk about technology. I think how does technology really affect our day-to-day? I think so. Here's a question for the group. In a recent survey, what percentage of physicians would recommend a mobile health app to a patient? Well, I think, this is a good question. But I think the correct answer is 80%. This comes from PricewaterhouseCoopers. We know, there is an explosion of mobile health, right? Means I think all of us here are using either Fitbit or something. If you have an iPhone 6 is tracking your steps, right? It also is tracking how, it does allow you to even track how much of chloride did you take or how much of magnesium did you take. I don't even know how to do magnesium tracking. But I think so PricewaterhouseCoopers said, the survey they did in 2010, 88% of physicians want patients to track or monitor their health at home. This whole industry is exploding. Recently at ATA, American Telehealth Association meeting, people have sensors for everything. You can, on your head you can place a hat, or on your bathroom rug you can stand and track yourself. And there are thousands and thousands of apps. And there is a consumer demand for this. We have patients coming to us and saying in a clinic, doctor, when I slept last night, my pulse was 80. When I woke up, it was 88. Usually when I wake up, it's 60. What's happening right now? And I don't know that. Yeah. I don't know what to do.
The Washington Post yesterday ran a feature article just on the subject.
Okay, good. So I think, yes, we have to meet the demand on how we can remotely access healthcare. People can remotely monitor things. So here are things we are trying to use. We have, yes, people do like talking to computers. We have a texting program right now. We have around 500 diabetic patients on this who receive motivational messages or their health messages to really see if we can lower their A1C, we can track their A1C and how they do it. We also have the wireless blood, congestive heart failure scales. I'm sure many of you in this room have those. Also the GPS-enabled sensors for asthma and COPD tracking, and the latest is the wireless blood pressure cuffs. But every week I have a vendor who wants to sell me some stuff, who wants to come to my office, because if I just purchase their product, I would save $7 million. And I don't know how they come with the 7. Every vendor has a $7 million. Everyone wants to save us money. So I think, but also the way we are delivering healthcare is changing. I think when we think about diabetes, do people have to wait nowadays 3 months to see their doctor? The access to healthcare has become such a huge issue that we are now trying to see how we can leverage telephone or televideo visit for where people do not need a physical exam. For example, diabetes management, you can easily schedule an online visit with your PCP or your endocrinologist or video visit and manage your diabetes. So that's something which we continue to grow, and it has its own nuances, but I think in just a snapshot, I want to share that with you. And this is just something we did with wireless blood pressure cuffs. Here you can see the dotted line of their blood pressure before they were in a telehealth blood pressure program, and the solid line are what their systolic and diastolic blood pressure were after they were in the program. And you can see there has been a significant control of blood pressure after they were in the program with the remote wireless scales, wireless blood pressure cuffs.
Was that Sharpry-Steely data?
Yeah.
So what's so exciting about that is you're replicating the Health Partners Minnesota study on wireless home blood pressure monitoring.
Well, that's nice to know. I didn't know that Health Partners had a study, but I think it's a lot of common sense here. I think so. So the way we are trying to really look at all this thing is, we are looking at technology as a way to complement or supplement our staff. We do not have enough people to really manage the whole population. We have to use technology or sensors to really reach out to a bigger group of populations. Let's say for diabetes, one nurse now today can reach a larger group of population and see if we can have the same outcomes. So this is where we have the technology going on. And then I'll just switch a little bit quickly to, now you have the team, you have the processes, you have the technology. And the one thing big which is missing is, how do you get physician buy-in, right? And I think sometimes, physicians are, I'll come to this point, but what do you think is the most effective way to engage physicians in a quality improvement project?
competition with each other.
Well, I think the B is the correct answer. And the reason I say this, it comes from this very famous book. But, physicians are smart people. They know how to handle multiple complex issues, multiple they handle the most difficult situations all the time. But the way we are trained is to see the people in front of us. When I'm taking care of seniors, I'm not thinking about all the people who haven't come to see me or what's happening with the person, with their chronic conditions. But we have to really simplify things, because when you're looking at population health basis, we want to make sure that what is it exactly that we want physicians to do? Do they know how to do the work? Do they have the resources? And are the physicians motivated? And the motivation could be two ways. One could be, like you said, the competition. It could be your intrinsic motivation that you need. And I think every physician wants to make sure that patients are receiving the right care. Every nurse practitioner, every PA, I truly believe in that, having worked with many. I think everyone wants to make sure that their patients are getting good care. And there could be sometimes extrinsic motivators. And I think the biggest motivator for now is for our physicians is time. And how do we really reward your time to really reach out to this population, either through incentive or through time off on their schedule? So those are the things we are looking at. But also when we have to really simplify things, here's for example, guidelines, there are for hypertension management, for Sharp's TV, which we just rolled out in the group. And there are guidelines on the JAMA, there are guidelines on UpToDate, you don't need, there are so many guidelines there. The reason we spend time on the guidelines is because it takes into account your local workflow, it takes into account your local culture. When do you send patients? When do you refer the patients? What is your local thing? So here our cardiology, nephrology, primary care, everyone got together and we looked at all the guidelines for hypertension. And for example, for us, I know Dr. Susan Ivy and Mary from Nazina are working on this. We decided not to have a 60-year cutoff. We thought that there's enough literature now, enough evidence that first of all, it was not GNC8, it was former members of GNC8, right? So I think this was very well pointed out to me by cardiology division. But I think we cut off those things, and learning from evidence from the best, like Kaiser, for example, and then the San Diego Collaborative, we are trying to get most of the people on ACE and thiazide diuretics as much as possible. But the purpose of your local guideline is to really take into account your local culture, and that increases the adoption of your workflows. And once it's posted on the EHR, people can click on it and see what's the thing. And this goes on for either hematuria or how do you take care of BPH or other things. And here, when people say to us, look, I have 500 diabetic patients, what do you want me to do? Which are uncontrolled. The way we try to say is, look, we will make sure that your uncontrolled patients come in front of you. But once they come to you, let's have 3 simple rules of success. Let's make sure that they have an appointment every 4 weeks, they have labs every 4 weeks, and we'll also make sure that we place all labs on your behalf. And then you titrate the medication every 4 weeks. If we simplify things in the 3 steps, you take every patient one patient at a time,